In this case, we're performing a robotic-assisted IVC filter removal. We will walk you through the exposure of the inferior vena cava, dissection around the filter, and the technique for safe removal, with particular attention to managing any struts that may have embedded into the caval wall. Here you can see an in vivo photo of our port placement. The patient is positioned in the left lateral decubitus position, and access is gained with a varus needle. After establishing pneumoperitoneum, we enter the abdomen using the OptiView technique with the first 8mm robotic trocar placed in the subcostal region. 3 more 8mm robotic trocars are placed along this axis, about 1 handbreadth apart, and this is followed by 2 12mm assist ports placed more inferiorly, triangulating the second, third, and fourth ports. These allow for vascular clamp passage, suctioning, and suture management by the bedside assistant. We begin by taking down the white line of Tolt on the right, mobilizing the colon medially to expose the retroperitoneum and gain access to the inferior vena cava. Countertraction is maintained using arm 1, while the fenestrated bipolar forceps assist with additional countertraction as needed. The bulk of the dissection itself is carried out using the monopolar scissors. One helpful cue to confirm you're in the correct plane here is that it should be avascular. If you're encountering bleeding, that's often a sign that you've strayed from the correct plane. This dissection is now continued cranially. Note the combination of blunt sweeping and cautery as needed using the monopolar scissors. As your dissection approaches the caudal tip of the liver, the duodenum will start coming into view, and extra care should be taken here to avoid injury. With the duodenum cochorized, you can now start catching glimpses of the IVC here. It is helpful to have your bedside assistant come in with a laparoscopic fan to assist with additional retraction as needed. The Raytech cigar is a great tool for this type of case. It gives reliable retraction and helps manage any bleeding points as we go along. Similar to open techniques, supracaval control is extremely important, and care is taken to establish this before proceeding with dissection inferiorly. We continue our dissection until we can clearly visualize where the renal veins insert into the vena cava. Here you can see the left renal vein starting to come into view. Dissection is continued along the anterior IVC, noting the first glimpses of the IVC filter struts. The filter strut that has extruded through the caval wall is carefully dissected free from the surrounding soft tissue. We continue our circumferential dissection around the vena cava to identify all extruded struts, clipping and dividing small venous branches as needed along the way. Here, the insertion of the right renal vein comes into view. Systemic heparin is administered in preparation for vascular control of the IVC. We create intracorporeal Ramel tourniquets using a red rubber catheter and a vessel loop secured with a clip. This is demonstrated here. In the same fashion, we apply Ramel tourniquets to the right renal vein as well as the supra-renal segment of the vena cava. Our bedside assistant then applies a Scanlon vascular clamp to the infrarenal cava below the IVC filter. A venotomy is then created using the scissors. Once the field has been suctioned cleaned, we turn our attention to removing the IVC filter using the monopolar scissors to carefully free it. It's worth noting here that based on prior experience, we've found that the large needle driver offers the best counter traction when handling the IVC filter. We've intentionally left this segment of the video unedited and at normal speed so that you may appreciate the meticulous dissection and patience required to free the IVC filter from the vena cava without causing further injury to the caval wall. The IVC filter is passed off to the bedside assistant. The venotomy is then closed using two CV5 Gore-Tex sutures in a bidirectional fashion from each end and tied in the middle, after first flushing the vena cava to clear any debris or thrombus. This technique is demonstrated here. For the sake of time, this segment of the video has been accelerated. The Scanlon vascular clamp is then released, as well as the Ramel tourniquets, and hemostasis is confirmed. It is our practice to apply an additional hemostatic agent at the conclusion of the case. Thank you for watching. If you found this helpful, we invite you to view our other educational content.